Good morning, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Sandeep Chopra, who is the Additional Director, Cardiology at Fortis Hospital, Ludhiana, Punjab. We welcome you, sir.
Thank you.
Sir, we look forward to hear from you on today's topic of discussion, Mexelitine, an unexplored antiarrhythmic drug. Over to you, Dr. Chopra.
Right. Okay, so I'm going to start sharing my screen now, please. All right, screen visible again?
Yes, sir.
All right, thank you, TaskMed, for this opportunity. I'll be talking about Mexelitine, a very unexplored antiarrhythmic drug. We use a lot of amiodarone in our CSUs, left, right, center. But this drug is an amazing drug, maybe not as a substitute for amiodarone, but an add-on therapy or a substitution or a replacement therapy according to the indications that we talk about now. So we just talk about a 56-year-old a woman who came with palpitations and breathlessness for 2 days. Her ECG showed a wide QRS tachycardia. For all of us, we know that wide QRS tachycardia would mean a ventricular tachycardia. There were no comorbidities. If you look at this ECG now, the QRS is wide and not very, very significantly high tachycardia, but yes, it's there. So what this patient got was a wide QRS tachycardia with LBBB morphology and with AV dissociation. So this is intravenous amiodarone bolus given, and you notice very carefully that these P waves have come in here. These are the P waves. I'm going back to the previous ECG again. No P waves seen here. QRS is wide, and the patient has tachycardia. This is after reversion with amiodarone bolus. So treatment as protocol in most of our hospitals is intravenous amiodarone bolus followed by an infusion. An echo was done which showed a dilated cardiomyopathy with LV dysfunction. An angiogram was done which showed a normal coronaries. Cardiac MRI showed a bilaterally inflammatory cardiomyopathy with extensive fibrosis. Query of viral etiology, maybe a myocarditis, and patient was put on beta blockers. Yes, they remain the standard treatment to prevent further tachyarrhythmias, and with oral amiodarone. Again, developed a wide QRS tachycardia. Look at the morphology changing again. So this is in spite of being on amiodarone, and given intravenous lignocaine, repeated VT episodes, elective cardioversion done with DC shock. That's a defibrillator shock with 100 joules. And this patient was continued on beta blockers and oral amiodarone. So provisional diagnosis was repeated polymorphic VT with LV dysfunction. So now what happens with amiodarone? We notice this on a long-term basis. Patients develops a prolonged QT. QT is the interval which starts from the start of the QRS complex till the end of the T wave. This is the QT interval. And remember that the corrected QT interval, which we calculate, should be less than 440 in males and 470 in females. So recurrent, slow, ongoing VT, patient had a lot of interventions done, like ventricular overdrive pacing, thoracic epidural anesthesia, and both attempts were futile. Further severe sinus bradycardia because the patient was keep getting pushed with the amiodarone, and this was refractory to atropine. Patient had a temporary pacing done, and then a catheter ablation was being considered. So these are very interventional procedures. So again, a patient underwent a minimally invasive bilateral thoracic sympathectomy. VT was still ongoing. Periodic DC shocks were administered. And there, this new drug comes in called Mexelitine, followed by low-dose amiodarone. With time, VT became infrequent. And after 48 hours of VT-free period, a dual ICD intracardiac defibrillator was inserted. So with atrial pacing, with the optimal dose of amiodarone, beta blockers, and Mexelitine could also be given, and the patient was discharged in a stable condition. So we all remember this, that Mexelitine is being added on to amiodarone. If the patient is tolerating amiodarone, we don't have to stop it. Obviously, it is a very good antiarrhythmic. but we add on Mexelitine along with amiodarone so as to prevent the long-term side effects of amiodarone. What is VT storm? That's ventricular tachycardia storm. A definition is electrical storm is defined as 2 or more hemodynamically stable VTs within 24 hours. VT recurring soon after termination of another VT episode. Sustained and non-sustained VT resulting in a total number of ventricular ectopic beats greater than sinus beats in a 24-hour period. So this was a definition in patients without an intracardiac defibrillator, but in patients with an intracardiac defibrillator, the most widely accepted definition of electrical storm is 3 or more appropriate therapies for ventricular tachyarrhythmias, including antitachycardia pacing or shock within 24 hours. However, this definition is not comprehensive as it fails to account for VT that is slower than the programmed detection rate of the ICT, VT that fails to terminate with appropriate ICD therapy and remains undetected by the patient. So clinical syndromes of electrical storms develops when a vulnerable anatomical substrate, such as that from a structural heart disease or scarring after an MI, is affected by a triggered event such as a premature ventricular contraction. So this is a structurally abnormal heart, and once a patient has a single ectopic beat, and this converts into a VT, and this is called electrical storm. Determining the cause of electrical storm is essential because treatment must target the underlying mechanism. These are the various morphologies of VT. Monomorphic means non-sustained, sustained, incessant, and VT storm. The others is polymorphic VT. Then there's something called a torsades pointis or TDP, in which you will have an undulating pattern on the ECG, and the treatment there is different. In DDP, do not give amiodarone. You're supposed to give intravenous magnesium. So what is the etiology of VT? The most important and the most common etiology is coronary artery disease. Then the others being cardiomyopathies, long QT syndromes, valvular heart disease. So how do you evaluate these patients? The first thing is obviously do an echo and an ECG, rule out structural heart disease, see for family history, and if there's no structural abnormality here, which is found here, you can do an advanced imaging like a cardiac MRI. So these are the etiologies. With a structurally abnormal heart can be a cardiomyopathy, which can be ischemic or non-ischemic. Non-ischemic would mean idiopathic, arrhythmogenic right ventricular dysplasia, hypertrophic cardiomyopathy, cardiac sarcoidosis. And if you have a structurally normal heart, you can have an outflow tract fascicular VT or papillary muscle VT. So these are the VTs which require an ablation. And the other primary arrhythmic syndrome is called the Brugada syndrome. Very rare, more common in the Japanese population, but we should all be aware about it. We can talk about it in another talk. And that is a very important talk which can cause a sudden cardiac death in your patients. So how do you manage this? The different treatment modalities being medical therapies like amiodarone, beta blockers, obviously, and Mexelitine, ablation therapy like catheter, device therapy like a defibrillator. So these are the management strategies for VT storm, correction of reversible causes. So if the patient has coronary artery disease, obviously, you have a patient with the anterior wall MI having recurrent VT, you take him to the cath lab, open the arteries up. If he's within the window period, treat the ischemia. In the ICUs, we get a lot of VTs with electrolyte imbalance. You can do that and correct the electrolytes like hypokalemia, hypocalcemia. Deep sedation and intubation with GA can help to decrease the sympathetic outflow. Antiarrhythmic drugs we've spoken about, intracardiac defibrillator, and a catheter ablation. So these are the therapeutic strategies we've spoken about. Antiarrhythmic drugs should be the first line management of VT or VT storm. The advantages, most of your population will be able to afford them. They have a rapid effect and decrease in the frequency of ICD shocks. Disadvantages are the side effects which we as cardiologists and physicians should be aware about. Like we talked about the prolonged QT interval of amiodarone. ICD's intracardiac defibrillator is for secondary prevention. It does not prevent VT. It has a mortality benefit, obviously. It does not prevent VT, but treats it as and when it happens. But the anti-arrhythmic drugs will prevent VT, which is very important. You can have a combination of both the medication and the intracardiac defibrillator. And the catheter ablation is a very specific thing done by our electrophysiology colleagues. So this is the Vaughan-Williams classifications. We've learned about this in our DM days, class 1, 2, 3, 4. Mexelitine comes in the class 1B list of drugs called the sodium channel blockers. Class 3 drugs are amiodarone and sotalol, very useful and very commonly used drugs, especially amiodarone, indication being the ventricular arrhythmias. For Mexelitine, again, post-MI, VT, idiopathic arrhythmic events, Mexelitine is an amazing drug. The doses being for amiodarone, you can give a 300 milligram bolus for VT or pulseless VT arrest for VF. Obviously, if it's VF, you need to cardiovert your patients first. Then 150 bolus for a stable VT, followed by 1 milligram per minute for 6 hours, and then 0.5 mg per minute for 18 hours. Lignocaine can be given as a dose of 1 mg per kg bolus over, and then 1 to 3 mg per minute. So this is the loading and the bolus doses and the infusion doses. The EP effects are sinus rate being slowed, QRS being prolonged, QTC prolonged with the amiodarone. The adverse effects that you should be aware of are hypotension, bradycardia, AV blocks. Sometimes because of the QT prolongation, the patient might develop a TDP, that's torsades de pointes, shows VT below programmed IC detection rates. The other being corneal microdeposits. These are on a long-term basis. Thyroid abnormalities, both hypo and hyperthyroidism can happen with them, but it's mostly hypothyroidism. Ataxia, nausea, emesis, constipation, photosensitivity, skin discoloration, ataxia, dizziness, peripheral neuropathy, tremors, hepatitis, cirrhosis, pulmonary fibrosis, or pneumonitis. For lignocaine, only given in a hospital setting is bradycardia and hemodynamic collapse, very rare. For IV metoprolol, obviously give it for antiretroviral MIs, especially with intravenous 5 mg, Q5 minutes up to 3 doses. Mexelitine, the dose being 150 to 300 mg 8 hourly or 12 hourly. The common adverse effects being heart failure, AV blocks, lightheadedness, tremor, ataxia, paresthesias, nauseas, and blood dyscrasias, but no marked EP effects on most intervals. QT can slightly shorten, not get prolonged, but shorten. Sotalol, intravenous and oral, can be used for similar indications. Procainamide is not very used. Mexelitine is approved in ventricular arrhythmias. US FDA approval is there. By the DCGI, it's indicated in the treatment of existing or anticipated ventricular arrhythmias and ectopic beats, such as those found after MI and in ischemic heart disease, for arrhythmia induced by drugs for idiopathic arrhythmic effects. So basically, the Heart Rhythm Society or the American College of Cardiology guidelines recommend Mexelitine in the treatment of VT. Mexelitine is amongst the recommended antiarrhythmic drugs to prevent or treat VT or VF, is amongst the most antiarrhythmic recommended antiarrhythmic drugs for patients with recurrent VT, symptomatic non-sustained VT on an adequately dosed beta blockers or a non-dihydropyridine calcium channel blocker, so as to improve symptoms associated with arrhythmia. So we see a lot of patients who come with Holters. They have small runs of VT, even when they are not symptomatic. You can start Mexelitine for such patients. It's a class 1B antiarrhythmic drug, a sodium channel blocker, structurally very similar to lidocaine, but orally active. Site of action being the Purkinje fibers. So oral congener of lidocaine, EP effects are similar to lidocaine. So it has no development of second degree or third degree block. in patients with normal conduction. The good thing, again, like I mentioned before, was no prolongation of QRS or QT prolongation. Patients with pre-existing conduction defects have a depression of sinus rate, prolongation of sinus load recovery time. So minimal effects on electrophysiology, unlike the other anti-arrhythmic drugs. So this is a very good advantage. No significant effects on hemodynamics, so no negative inotropes. Blood pressure and pulse remain essentially unchanged. It's well absorbed orally. Peak blood levels are within 2 to 3 hours. Its first pass metabolism is slow. It is excreted unchanged by the kidney in 10%, and the plasma elimination half-life is 10 to 12 hours. So administration with food or antacid is recommended. Initiate with 200 every 8 hours. When rapid control is not essential, minimum 2 to 3 days between dose adjustments, and can be up titrated or lowered down by 50 or 100 mg at one time. So when a rapid control is required, you give a loading dose of 400 mg, and then later on 200 mg, and then chronic treatment like TDS. When rapid is not essential, 208 hourly, 308 hourly, and 408 hourly. So you go up slowly. When you're trying to up titrate these doses. So 208 hourly to start with, going up to 400. I would rather wait for a couple of days in between when I step up these doses. Where is it contraindicated? In cardiogenic shock, in pre-existing secondary AV block or third-degree AV block, if no pacemaker is present. Sometimes patients can develop a reversible gastrointestinal and nervous system adverse reactions with upper GI distress, lightheadedness, tremor, and coordination difficulties. So this is how you treat a sustained monomorphic VT. Obviously, if there's hemodynamically unstable VT, you directly cardiovert. If it's stable VT, you start with the myodrone or sotalol, and then and then you give Mexelitine to start with. If there's structural heart disease, on a long-term basis, you can give oral myodrone or oral Mexelitine. So summarizing, is indicated in sustained ventricular arrhythmias. It is an agent with moderate potency, has appreciable safety, safe in LV dysfunction, safe in QT prolongation, reversible non-lethal effects. Class 2 recommendation by the guidelines for management of VT, can be used as an add-on therapy for myodrone, with the myodrone, sotalol, beta blockers, and in patients with an ICD. So the management of ventricular arrhythmias, tachyarrhythmias, involves 3 major modalities of treatment: medical, device like ICD and catheter ablation, and often an hybrid therapy. We might have to put an ICD and then start Mexelitine. Treatment of VTs can be a challenge and needs to be individualized. ICD is the first-line therapy when you have a sudden cardiac death with high-risk polymorphic VT. Catheter ablation considered early for recurrent symptomatic idiopathic VTs, or as second-line therapies in sudden cardiac death. Medical therapy is acceptable for minimally symptomatic idiopathic VTs and low risk group of pleomorphic ventricular tachycardia. Thank you very much.
Very well elaborated, sir. So I'll request the participants, if they're having any query, they can put in the chat box.
I think that should be all.
Definitely, sir. I think we can wrap it up.
Right. Thank you very much, Hemanji.
Thank you, Dr. Chopra, for joining with us today. It was really an insightful discussion for us as well as for listeners. And I would also like to thank all the doctors for being with us and for the active participation during the session. Thank you and have a great day, sir.
Appreciate that. Thank you.